Okay, I am now. Thanks. I just got to get used to this format. Okay, I'm 74 years old. I'm going to be retiring at the end of this year. I closed my practice in April so that I could devote time to teaching and training. And we'll be doing that for another year. Was practicing for 40 years, 38 of them with ISTDP in one form or another. So the seminar that I originally planned was going to be 2 3-hour trainings using videos and some observations after all this time. And people said, could I tell some colleagues? And I said, sure. So there's like 90 some people now that are attending that, and split some in Europe, the US, and the Middle East. And then I have to do a separate training for people in Australia because of the time difference. And as I was getting to know each of you through your email, it became clear that a few of you have had not much experience with ISTDP. And I kept thinking maybe you shouldn't come because most people at the trainings have had significant experience. Some of them teach, train, and supervise themselves in ISTDP. And then I thought, well, no, I could just do this hour seminar, no charge, no problem. It's a Sunday morning. And I could probably convey enough information to bring everyone up to speed enough that you could understand what was going on and get something more out of the trainings than you would have just going in cold. And so I was expecting about 10 of you. Well, now there are 47 of you. So this is how it's going in my life. I have no idea why. I'm just kind of had a low profile for years, and people just kind of find me. I'm not an institute or anything like that. And I guess that's how all of you are here. You just kind of found me. So it's great. Some people here do this all the time. Some people here some of whom I know and adore, teach classes, teach graduate level classes in ISTDP. And so an introduction to ISTDP is part of what they do every semester. And it's really nice to have everyone here. And but I'm going to be speaking to the people who don't have the experience. That's what the focus is going to be. And I thought we could spend an hour doing that and then take a short break if people want, and then I'll just hang around for an hour if people want to unmute and ask questions. And maybe some of the people who do this all the time, that do these introductory classes at the graduate level, could weigh in with what I could have done better, or what I missed, or what I got wrong, or how their perspective would be different from mine. If they're willing to do that, that would be great. But meanwhile, I'm going to be focusing on the newbies. And the rest of you assholes will just have to wait, because I won't be talking to you. I'll be talking to the new people, and hopefully get you up to speed so you can get a lot out of the trainings. If after this you decide I'm not worth your time, or that ISTDP is not a good fit, or I'm not a good fit, if you've already paid for the trainings, I'd be happy to refund your money if you decide you don't want to go. And so I'd like to start with a historical perspective. ISTDP, intensive short-term dynamic psychotherapy, was developed by Dr. Habib Davanloo. Dr. Davanloo was born and raised in Iran. He was a colonel in the Iranian cavalry. He's in his early 90s now. As far as I know, he's still alive. I haven't spoken with him probably since mid-2017. I know he stopped all teaching and training, but given that he's that old, being in the cavalry probably meant horses back then, instead of a fast-moving military unit like it does now. Then he was trained as a surgeon in Paris, and then he came to the United States to do a residency at Mass General and Harvard in psychiatry. And he then went to McGill University, where he was a clinical professor of psychiatry in Montreal. And when I first met him in 1982, he was a clinical professor of psychiatry at McGill and director of the Short-Term Psychotherapy Institute at Montreal General Hospital. And the protocol when he was a resident, this is in the early 50s, was psychodynamic psychotherapy, which was a derivative of psychoanalysis. And basically the therapist would be a blank screen, and the patient would project their core neurotic conflicts onto the therapist, and then the therapist would make interpretations. But given how the rotations were set up, the rotation would be over before the patient could work out the transference neurosis. And so the patient would be left with the transference neurosis on top of whatever brought them into therapy in the first place. and they developed institutional dependence. And also, it was actually very cruel to the patient to have the rotation set up that way. If you're doing long-term therapy, which it was at the time, you should have long-term rotations. But being a resident, Davanloo just went through this because that's what you're supposed to do. You kind of take orders as a resident. But once he got out into the world and started practicing and looking back on it, he felt very guilty about being part of a system that was so inhumane to patients. And so he was resolved to come up with a therapy that would bring about the character change that psychoanalysis was purported to bring about, but probably seldom did, but in 40 hours or less. And we often speculated that given, Christmas vacation and missed appointments, that 40 hours that was the number of sessions that someone could offer being a resident at that time. And so when video technology became available, he started recording all of his sessions. This was probably in the early to mid 60s, and those big Sony Betamax machines with the little screen. Those of you who are older probably remember those. And he would record his sessions, all of his sessions, go over them line by line, form a hypothesis, do 5 sessions this way, do 5 sessions that way, go over the recordings again. Patients were brought back 6 months, 1 year, and 5 years after their therapy was finished. And part of the exodus, part of that interview involved them watching recordings of their sessions. And they would weigh in and they would say, I was fooling you here, or it was helpful when you did this. They would say things like, oh, look at me, I can't believe I was so crippled. Words like that would pop up during these interviews that Davanloo realized were universal, and he would incorporate them in his therapy. So what are you going to do about this crippled man? And so he systematically compiled all of this information and didn't go public with it until 1979. So it was 15 or 16 years of this development. And I met him in 1982 and went to a training. He had a severe definition for a successful therapy. A successful therapy was no return of presenting symptoms in 5 years. That was it. Did he succeed all the time? No. Does any therapy? No, obviously not. But he had a very high success rate. And his successes were pretty spectacular, like people were just kind of transformed. And so he comes from a psychoanalytic tradition. Like that's his, in fact, he insisted all along, again, I haven't spoken to him recently, but he insisted all along, I trained with him for 4 years in what's called core group training, that he did not create a new system of therapy, that he was merely adding to the body of psychoanalytic knowledge. And indeed, it comes out of psychoanalysis. He went through a training analysis and so on. And the thing with psychoanalysis, the curative element in psychoanalysis, going way back to Freud and Charcot and Brewer and this is the beginning of our profession. This is how it started. The curative factor was, if you make the unconscious conscious, then people's symptoms disappear. So whatever feelings, thoughts, traumatic events people are repressing and not allowing into conscious awareness, if you bring them into conscious awareness, that's where the healing takes place. And there was a lot of early successes treating hysteria. I think Bill Watson, he's just sent me an article recently that sort of recounted some of those early days. And they were spectacular. People would just stop being hysterical, or people would stop. But the problem was it didn't work with everybody, and it only worked with certain people. And so they tried everything. They tried hypnosis. They tried urging people to experience their feelings. And they finally settled on free association. And so the basic problem was resistance. If you were dealing with low resistant patients, good luck finding them, by the way. Davanloo actually he intended his technique to be for low resistant patients. Initially, he called them symptom neurotics, meaning you just like change is a little scary, so you lean on them a little bit and they have their feelings. He couldn't find enough people, like in 2 or 3 years, he could only find like 4 people that were that healthy. I mean, they do exist for whatever reason, but, and there's this other therapist, famous short-term therapist, Peter Sifnios from Harvard. That was his whole thing, was, short-term therapy, but with symptom neurotics. And I worked with one of his people who did a residency. Her first name was Peggy. I can't remember her last name. And she wanted to learn his technique. And she said he was brilliant, but she couldn't find one person healthy enough during her residency to practice the technique. We speculated that Sifnios kept all the healthy patients for himself and sent all the other ones to the interns, return residents. But so he had to expand it. And he defined the next group, which would probably be me, not probably, me and probably most of you, as character neurotics. And character neurotics means that there isn't just resistance because change is hard. There's resistance due to this superego, self-sabotage and self-defeat. And so it's resistance in the form of self-sabotage and self-defeat. And that's the major problem. I don't care what sort of therapy you're doing. And I know there are people here from various backgrounds, which I think is great. And I think integrating all of these various schools is sort of one of my pet projects before I retire. But the problem, think about it, in all of your therapy is resistance. Like, what do you do about resistance? What do you do about people who essentially are not doing their part of the job? You know, I recently had a hiking injury, which I'm, mostly recovered from. And I had a great doctor, brilliant doctor, a brilliant orthopedic, trauma specialist, and a great physical therapist. But I had to do my part of the job. I had to keep my leg immobilized. I had to do physical therapy or I wouldn't get better. It's the same thing with psychotherapy. If the patient isn't doing their part of the job, nothing happens. Like, it takes both of you doing your job. And people resist, people get defiant. People get angry and don't tell you. People get compliant and they're nodding during the session and then they leave and nothing happens. There's this whole thing about resistance that's problematic. And every school of therapy has their own way they deal with resistance, right? If you're Ericksonian, you start inducing trances. If you're doing EMDR, you start tapping on people's hands. If you're CBT, you start giving people thoughts to replace their irrational thoughts. I actually had a form of behavior therapy called rational emotive therapy developed by Albert Ellis when I was 17 and depressed and didn't know what I wanted to do with my life. And he was telling me how I should think, that's irrational. And then I would leave the session and I would just forget about it. Like, I didn't practice, I didn't do anything, so it didn't help. And so what Freud did, what psychoanalysis did with resistance, is they came up with free association. They would just kind of figure that if you come to the session 1 hour a week or 1 hour a day for 5 days a week for 12 years, and you lay on a sofa with your therapist sitting behind you in a chair taking notes, that somehow that will overcome resistance, which it may for some people, but not much. And psychodynamic psychotherapy tried to make that distilled into a more practical form where you could come once a week and listen to interpretations and so on. And that probably helps some people. But Davanloo realized that if he was going to do really an effective short-term therapy, that he had to deal with resistance in a different way, free association just wasn't going to do it. And what Davanloo came up with, which is the key to his approach, is you're going to be honest with the patient. It's an emotionally intimate relationship. And if the patient is being resistant, you're going to, in real time, which is all you're going to immediately bring that to their attention. And it goes something like, okay, what brings you here for, this is a condensed version and it sounds kind of simple and straightforward. And sometimes it is, but we all know people are complicated and getting into the complications is not within the realm of what we're going to do in an hour. But someone comes in and you say, what brings you here for therapy? And she says, depression. And you ask about her depression and find out that she's not suicidal and, that she can handle therapy. And then you say, well, is your depression more intense at some times? Even though I know it's pretty constant, does it get worse? And she goes, yes, it does. Well, could look at a time recently when it was especially bad. And she says, well, my husband didn't come home for dinner and didn't call and turned off his cell phone, and the kids and I didn't know where he was. And he came in at 10 in the morning the next morning, and he'd obviously been drinking and he's obviously been with another woman. And I would say, well, wow, how did you feel toward him? And she said, I was mad. So what did you say? What you're doing is portraiting. Where were you sitting when he came in? Were you in the kitchen? Because that's where feelings occur. They don't occur out in the ether. This is one of Davanloo's discoveries. They occur at 10 o'clock in the morning when your husband walks in disheveled and looks like he's been out carousing. And she said, she would say, this is a composite. I'm sitting at the kitchen table and he comes in and what did you say? I said, how could you do this? The kids and I were worried. And what did your husband say? He said, well, if you weren't such a bitch, I might come home more often. And oh, now you're going to cry. You know, you're such a pathetic wife. I can't believe, you know. So who among us wouldn't want to strangle that guy? Like we would have this fantasy that would be very satisfying. And now you're crying. Look at you. Look how pathetic you are. Now you're crying. She's telling you this. And then you say, well, were you crying? And she said, yes. And you would say, well, so you mean you started to feel anger and then you started crying, and what was going on inside of you then? And she would say, I was thinking he's right. I'm a terrible wife. If we had sex more often, if I cooked his favorite dinner more often, if I kept the house cleaner, I really don't deserve a husband. He probably should stay away. So you started beating up on yourself. And she would say, well, yeah, you're right. I was. And I would say, so when you were beating up on yourself, what happened to your anger? Was it more prominent or did it fade into the background? And she might say, no, it wasn't there. It totally disappeared. Do you think that beating up on yourself could be a mechanism that you developed to avoid the internal experience of your anger? Do you think that's a possibility? So if she says, yes, it is, you're right. That's right. I can think of it. I can think of other examples where he did something and then well, could we look at if you don't go to beating up on yourself, if you don't develop this pattern of low self-esteem, how were you experiencing your anger at 10 a.m. on Wednesday morning? What did that feel like? Well, I don't know. All I can think of is beating up on myself. So what you begin to do under Davanloo's system is you begin to pressure for the experience of the feeling. That's very disturbing when you do that. What you're doing is you're sort of brushing past her defenses and pushing for a feeling that she's been blocking since she was 5 years old. And it's very disturbing. And she starts to develop feelings toward you for doing that. And they're mixed feelings. Davanloo called that the complex transference feelings, meaning a part of her is pissed at you, like, don't fuck with these defenses. They've been my best friends since I was 5. And at the same time, wow, this guy really wants to get to the truth. He's not getting fobbed off by the superficial bullshit that I present to everyone else. And he wants to get to the truth. And you're also putting the superego on alert, like, we're coming after you, buddy. We're going after you, buddy. And it's a very, so now she's going to defend against those feelings toward you the same way she does with her husband. So now it moves into the transference to what's happening in real time between you and your patient. And that's Davanloo's way of dealing with resistance. You let her know. You're honest with her. You're emotionally intimate. Do you notice that as we try to get to the experience of your anger toward your husband, that you're distancing in here with me? You're doing the same thing with me that you did with your husband. Do you notice that you're shutting down? Do you notice that you're getting weepy? Do you notice that you're getting passive? It's important that you look at that. Do you see what I mean? And it's important. It's the brilliance. One of the brilliant things of Davanloo's work is that now we have live between the two of us the exact thing that brought her into therapy in the first place. We're talking about it now with an experiential component, which accelerates the therapeutic process. We're not talking about it out there in the ether somewhere. It's like, look, right here. She may not be willing to take down the wall, but you have to say to her, if you leave this wall as it is, we won't have access to your intimate thoughts and intimate feelings. I won't be able to help you. Davanloo used to say, I'll be useless to you. What you're doing is you're telling her the truth. You're being intimate. You're modeling the very intimacy that you hope she will exhibit as a part of her healing process. You're not just sitting there as an attached observer giving her assignments. You're being honest with her. You're not sitting there frustrated and maybe doing a reaction formation as she's weepy and poor me and a victim and trying to be supportive, you know, and maybe being aggravated with her, you can really say, this is what's happening. Do you see what I mean? And if you stay behind that wall, I won't be able to help you. And is that really what you want? You go to her will. Do you want to stay behind the wall? Do you want to waste our 4 hours? This could be one more relationship that you don't get out of it what you want. If you don't take down the wall, then you can look at depression on the horizon as far as you can see. Davanloo used to say, then you can take this depression to your grave. Is that what you want? And you can be honest with her about how you're feeling. You can't say, well, I'm neutral. I don't care whether you take down the wall or not. That would be dishonest. I mean, you're a therapist and you've already established a relationship, and here's this suffering person. You can be honest with her and say, if you decide to leave the wall up, I will feel bad. I want to help you. I see all this potential that's being crippled, and I will feel bad. I would go to my colleagues. I would show my video. I would figure out what I could have done better, but I'm in a profession where I can't succeed with everyone. You see how honest that is. But I'm not neutral. I would feel bad if you decided to leave the wall up and our therapy failed. But I can handle that. I'm in a profession where I can't succeed with everyone, and I can handle feeling bad. You don't have to make this change for me. But how would it be for you to leave here and not get the help that you came for, to have this be one more relationship that you didn't get out of it what you want? How would that be for you? So what you're trying to do is help her become a partner. Help her get to the point where she says, no, you're right, I don't want to do this anymore. So needless to say, all of this will create a lot of emotion. This is really distressing, right, for people. And you have to be able to assess what's happening with that distress. Like, this is like, you know, you just sort of lobbed a hand grenade over her defenses, and what's going on the inside? Okay. So here we have, voila. No, I don't want that one. I want, let's see. I want this one. We have the triangle of conflict. The triangle of conflict was a concept developed in the early 50s by a psychiatrist whose last name was Ezriel, E-Z-R-I-E-L. It appeared in an article in the Journal of Psychodynamic Group Therapy. They probably had like 5 people who read that journal, you know. It was an esoteric journal, but it was an important concept that was later incorporated in the manager clinic. And so Davanloo took it to the next level. So at the bottom, you'll see feelings, right? Davanloo added impulse. Every feeling has an impulse, which is an urge to act. If you're feeling loving, you want to hug someone, you want to do something nice. If you're feeling afraid, you want to fight or flight. Anxious, if you're feeling remorseful, you want to make amends. If you're feeling sad, you want to grieve. If you're feeling angry, you want to lash out, physically, verbally, or both. It's a very primitive part of the psyche. That's what Davanloo's therapy deals with, this primitive part of the psyche. And that's what makes anger, for some people, the most difficult feeling to experience, because they want to lash out toward people like their parents, who also they love and who love them. And so it's a feeling that often gets repressed. So when this feeling gets repressed, if it gets triggered, which we're triggering it, right, in this hypothetical session, we're triggering all these feelings. And we're not only triggering feelings toward me in real time, but we're stirring up feelings from the past, right? We're stirring up feelings from their current life as well as from me. Those are all getting stirred up. And even asking someone, what brings you here for therapy? That question alone stirs all this up, going way back to their past. They're not aware of it. You're not aware of it. You know, I mean, theoretically, you're aware of it. You don't know what it is, but all this is getting stirred up. And if a feeling that you've worked hard to repress your whole life starts to break into conscious awareness, which is happening, right? She's getting pissed at me. You get anxious. This kind of anxiety is what Freud called a signal anxiety. It's one of the things from Freud that's really solid. Obviously, not everything is, but certain things are. And it's like there's this alarm bell going off, da-ding, 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 da-ding. An unacceptable feeling and impulse is about to break into conscious awareness. And this anxiety is crippling. The kind of anxiety that comes from down here, from the bottom of the triangle, is mobilizing. It's like you're in danger. It's like you can focus and your body gets mobilized. And it's this kind of anxiety up here is crippling. It can lead to panic attacks. It can lead to physical symptoms. It can lead to back pain. It can lead to tremors. So what Davanloo did is he actually mapped out the biological pathways of that anxiety. He mapped it out, looking at those videotapes day after day, hour after hour for 16 years. He mapped it out. And he found that that anxiety in the body goes 3 different ways. The first way, if it's not too intense, is it goes into the striated muscles. And you'll see that. You'll see striated muscle activity. You'll see people taking a sigh, which is the intercostal and subdiaphragmatic muscles. You'll see people like this. They're sort of, I assume people can see me, kind of an organized, the pronator and supernator muscles. And so with that woman, when she starts blocking her feelings toward me in the same way she does with her husband, when she starts repressing and becoming compliant and becoming weepy, I'm looking for signs of striated muscle tension. It's really important that I see that. Because if I don't see that, then the anxiety is going 2 other places that aren't very good. The first is to disrupt the cognitive functioning, cognitive perceptual disruption. Okay? It can be mild, where people can't quite follow what you're saying. It can be more intense. A woman that I saw, her father tried to take her baby away from her, and this whole scene happened, and she was walking out of the house, and the next thing she remembers, she's on the father's back, like strangling him. And the mother and the sister are yelling at her, putting her off. She had a complete blank out. She did not remember the baby was safe on the grass. She did not remember what happened. It's an extreme form of cognitive behavioral disruption. With her, I didn't put much pressure into the system because that would have been me being strangled. There is a process of restructuring then where you can bring the anxiety down and bring it back into the striated muscles, which is well beyond the scope of an hour. But you want to know what's happening with the anxiety. And if you're not seeing it in the striated muscles, the muscles that you can voluntarily move, you want to find out where it is. And you can ask, is it disrupting the cognitive functioning where the patient can't follow you? The second place it will go is into the smooth muscles, the muscles of the autonomic nervous system that you can't voluntarily move. So we'll go into the GI tract, for example, and people will develop things like nausea and irritable bowel syndrome. And so you have to know where anxiety is going. If it's in the striated muscles, I can put more pressure. I can say, well, that's a defense and that's still the wall. And if it's going to the GI tract, you can't put any more pressure in for a while because the person is running to the bathroom with irritable bowel or getting nauseous. And if it's disrupting the cognitive functioning, you can't put more pressure into the system because the person will disorganize or develop tunnel vision, or the room will start spinning around, or the most extreme form, they'll pass out and their head will be lowered, and then the blood will go back to the brain. So Davanloo developed this system, this sort of interactive diagnostic system that you can be aware of what's going on inside the patient from moment to moment, which is vital. It's just really important. And so, and there are ways to deal with that, a lot of which we'll go over in the seminar. Okay, so the second thing is defense. Okay, so this woman, right? She started to feel angry. We all want to strangle her husband, but she couldn't allow herself to feel that, mostly because the husband probably represents someone from her past. So she gets anxious, which you can go over with her. And then the defense is to attack herself. I'm a terrible wife. If we had sex more often, he would come home. If I cooked his favorite meal, that helps her manage the anxiety because it takes her even further away from this anxiety-provoking feeling and impulse in her unconscious. And so that's her defense. And she's probably had that since she was a kid. So for example, since kids are so transparent, if your kid is feeling angry, people who have kids or have had kids, you can see it. The ego isn't developed enough to mediate. And so if every time you feel angry, your mother starts shaming you, right? And abandoning you and telling you how terrible you are, so your mother's anxiety goes up. And you realize that when you're feeling bad about yourself, that your mother's anxiety goes down and she can be around and be a mother. Guess what you're going to do? And since you're so transparent as a kid that you can't feel anger without showing it, you're going to figure out a way not to feel it. It's not conscious, it just happens. So when I feel bad about myself, my mother is around for me. So who's the guy? Gabor Mate, M-A-T-E, circumflex, or accent aigu on the E. He says this so well. He says, when kids are presented with a choice between authenticity and attachment, they pick attachment. Like you're dependent. You can't survive without your parents. And so in abandonment, as Freud talked about, the separation anxiety is experienced as a death. So it makes sense that you would opt for attachment and feel bad about yourself and keep your mother in the room. That's getting played out with the husband who's shaming her. The same thing is getting triggered. The same thing that developed in the past is now getting triggered in the present and getting triggered by the therapist. It's exactly the same pattern. And think about how often you make that decision to forego authenticity as an adult in favor of attachment. How much of your life do you spend trying to be liked or trying to manage other people's feelings about you or manage other people's anxiety about you? It's a common human thing. So what Davanloo is doing now, what he suggests and what he practices is that you begin to acquaint the patient with this triangle of conflict. So as we begin to approach your feelings toward me in here, that mobilizes a lot of anxiety in you, and your thinking becomes clear, your thinking becomes cloudy. Do you see what I mean? There's something about, as we approach your feelings toward me in here, that mobilizes anxiety in you, and then you begin to beat up on yourself. It's important that you see that. And you're instructing the client about the triangle of conflict. And now do you see you're getting helpless? Getting helpless, you're getting anxious, then you take a helpless position, then you get weepy. And how much of your life have you spent feeling helpless and weepy? And how much more of your life do you want to spend that way? So we're here to get to the bottom of this so you don't have to spend your life depressed and helpless and weepy. It's really, it's important. And so when you're looking, and this you could apply to any therapy. This is just data that Davanloo, being the craftsman that he was, the surgeon, the precise surgeon, is helping us see that this is what's going on. Okay, so let's see, what was I going to say? So if someone is crying, okay, you want to know what part of the triangle is that crying coming from? Is it coming from the bottom of the part of the triangle where it's genuine grief? Because most people, or is it coming from up here as a defense against anger? Is it weepiness and being a victim and poor me and depression? Davanloo is giving us the tools to see that no matter what form of therapy you're using. It would be important to know if this person is crying, where is that coming from? So from here, it means this anxiety is too high and it's getting discharged in the form of weepiness. And there's ways to determine that. Again, that Davanloo figured out that he's spoon feeding the rest of us to determine that. The most difficult thing in terms of people's concepts is anger. So if you're starting to feel anger down here, and then you get anxious, your defense could be to have a temper tantrum, or what Davanloo would call explosive discharge. You could start yelling. You could kick in the screen door. You could punch the wall. You could just say sarcastic things. Like you could just be mean. You could give someone the cold shoulder. That's not anger. That's what most people think is anger, but it's really anxiety being discharged in the form of a temper tantrum. If you're really feeling fully the anger and the impulse, which is the impulse to lash out, there isn't any of this happening. And it's like someone undid a valve and you can feel the anxiety flowing out of your body, and you're really present, and you can feel the anger, and then you can feel other feelings. There's a fluid kind of contact. So one guy I saw who's an accountant, he was working his way through college at a local supermarket chain, Tops, because he said, well, I can't deal with anger. And I said, why not? He said, because it gets me into trouble. So of course I said, well, let's look at the time it got you into the most trouble, because maybe he hit his therapist or something, right? You want to know that you're safe. And he said he was working, the manager at Tops, when he was working there, said something mean, and he shoved the shopping cart toward the manager, and the manager shoved it back, and he picked up the manager and turned him upside down and threw him on the floor and stormed out of the store. That was his version of anger. If I was asking him to experience anger and he thought that's what I meant, what happened at Tops, he wouldn't experience. I mean, why would anyone want to experience that? It feels bad. So there's ways of separating these two parts of the triangle. So later on in the session, I was pressing him for feelings, and he was starting to feel anger at me. And finally, I said, what's going on with that fist? And he said, I feel like I want to punch you. And I said, so you're angry at me? And he said, no, this isn't anger. And I said, what do you mean? You feel like, but you see, he's talking to me. He's in touch with, we're having a conversation. He's also feeling his positive feelings toward me. And I said, why, if you want to punch me, why would you say that's not anger? And he said, because this feels good. And I said, well, how does that compare to the incident at Tops when you were working your way through college? He said, it was like my mind was in a hurricane, like I was losing control. You see, he was experiencing anxiety, and the defense was to discharge him in the form of a temper tantrum, which he lost his job. I mean, why would he want to go through that again? So this is an important concept, and it's really hard to get across without a video, but maybe a personal example would help. Many years ago, I was part of a committee, and we were tasked with getting a project up and running. And we had 6 meetings to do it. And we decided in the first meeting that the first 4 meetings, we were just going to blue sky any and all ideas on the table, a free flow. In the 5th meeting, we were going to pull together the best elements from those brainstorming sessions into a plan. And then the 6th meeting, we were going to assign action items to implement the plan. So we got to the 6th meeting and we started to assign action items, and one guy kept disrupting the meeting. Whoever talked, he would say, I don't know. I don't think this is a good plan. I don't think I can get behind it. And you could see everyone was getting aggravated, and people were rolling their eyes, and people were trying to explain that this is not the time for this. And you go, I don't care. I can't get behind. When my anxiety goes up, this anxiety, this crippling anxiety, because I'm not feeling this, I get tired. And so I was like slumping in my chair, like, oh God, I hate meetings. I could do therapy all day long, but meetings really suck. It's such a drag. And I noticed that I was holding my pen like this with the point. And all of a sudden I had this fantasy to put my hand behind the guy's neck and jam my pen into his voice box. It was so satisfying. And he was bleeding, and I shut him up, and it was like, well, my anxiety lifted, and my mood picked up, and my thinking got clear, and I had all this energy. If you were looking at me, you wouldn't have noticed, but like I wasn't going like that. If you would notice, it was just what I was experiencing on the inside. I would sort of be like this, and you would sort of see this energy coming into my face. So now with my thinking clear and my anxiety down, I listened to him, and I could really listen, because I wasn't in my defenses going, what an asshole, you know. And he was right. He was absolutely right. We didn't have enough time to do it right. 6 meetings is all we had, and we got to make do, but it wasn't right. And I said that to him. I said, you're right. I said, we really didn't have enough time to do this right. And this plan could be better. And it's kind of risky going ahead with it. And he interrupted me and he said, yes, but this is the meeting when we're supposed to assign action items. And our 2-hour meeting was like over in 45 minutes. He was just looking for some acknowledgement. I mean, he was doing it in the most off-putting way you could imagine. I mean, everyone was pissed at him. But as soon as he got the acknowledgement, he was fine. But I wouldn't have had the clarity to do that until I experienced these primitive impulses that we all have, every one of us, or probably most of us anyway. And so it's important to know if someone is angry, and you'll see this in the videos. The guy who I'm going to show in the first training has a temper tantrum. He's like screaming at me, like, shut the fuck up, asshole. That's all coming from up here. And we had to separate those parts of the triangle. And later on in the session, he feels fully his anger at me, and of course who I am in his unconscious, and the impulse, and he's different, he's engaged, we're having a conversation. The positive feelings for me then come up. And so this is such a misconception. Davanloo nailed this, and most people just don't get it. Most people think anger is when you're screaming and yelling or saying something mean or being sarcastic. It is not. It feels bad. If you're telling people to experience anger and they think this is what you mean, why would they want to experience that? Why would any rational person want to experience that? It feels bad. It's destructive. But once you separate these parts of the triangle, which they are kind of mushed together, the anxiety and the feeling impulse, then you can say to experience anger, and then they understand what you mean. So it's really an important, so the same thing, when someone is angry, is that coming from here in the form of a temper tantrum, or is that really the feeling? Does it mean their anxiety is too high and they're discharging? Or is that really the feeling? And there are ways to make that determination that are, again, beyond the scope of this work that we're doing in an hour here, but it's very important. The same thing with sadness. Is this defense because they're against anger and this person is getting weepy, or is it sadness? Is this anxiety coming from the bottom part of the triangle where they're really in danger and they're getting mobilized, or is it this kind of anxiety? So it's important to make those distinctions, and Davanloo figured all that out, the pathways. He also mapped the biological pathways of anger. Like there's a biological pathway that when people are really fit, which again, you'll see in the first video, it starts in the abdomen. It's a warm feeling. It comes up through the center of the body and out through the arms. And you'll see the patient describe that. You'll see him describe his anxiety and then later on the anger. He says it feels like something warm that wants to come up. And again, he's focused and we're talking and we're, you know, if I come up to someone and I'm in touch with and I go, oh my God, what you said at the meeting yesterday, I'm so mad at you for saying that I just feel like strangling you. That's how mad I am. The person can say, really, what did I say? And I would tell them and they go, well, no wonder you feel like strangling me. I really put my foot in my mouth. I'm sorry. But if instead I go up to them and say, you're a jerk, you're an asshole, and I start discharging from up here, you can see that that's a whole different conversation. It's not intimate. And so when I talk about people about intimacy, like the woman, the hypothetical woman who's distancing, intimacy is experiencing and communicating what you're feeling. It's not acting it out. Okay, so Davanloo figured all this out. No one else had. When I read about anger, I still see that most people outside of ISTD people don't get it. And when people in other forms of treatment talk about regulating your anger, you don't want to regulate your anger. You want to feel your anger. You want to regulate the anxiety. And even then, if you're doing that form of work, you want to make that distinction. You want to regulate your anxiety. You want to feel your anger because that brings your anxiety down. That makes you more connected with yourself and more connected with other people. And Davanloo figured that out, like from scratch. He got it. And These are all things that you can apply to any form of therapy. This is data that's right in front of your eyes. What part of the triangle is this coming from? Is it a feeling? Is it a defense? There are higher level defenses, as you'll see in the video. People can ruminate, people can intellectualize, people can become workaholics, people can, there's a whole bunch of things. And interestingly enough, like I've seen a lot of therapists from all disciplines over the years in my practice, that our training as therapists becomes an extra layer of character defense. We actually think that because we understand something and that it's the same as feeling it, and it's not. It's fine. It was a nice challenge. I was that way as a therapy patient. I can see in hindsight that I was trained in ISTDP and then went into ISTDP therapy, and it just became an extra layer of character defense. The idea is at a primitive level to experience what you're feeling so that you're not living a life here and here. So it's a hard thing to convey without a video. It'll probably become clearer when I show videos, but okay. The last thing is that as you begin to determine that the anxiety is, one more thing really quickly. If the defense is depression, if you're mobilizing feelings and there's anxiety, and then the defense is depression, you can't put more pressure into the system. You have to back off. And again, there are ways to handle that are beyond the scope of an hour, because as you're pressuring people for feelings, well, that doesn't say how you're feeling. If you don't become crippled, if you don't get weepy, how are you feeling? The person is getting more depressed. And then the ego is depleted. And then how is that therapeutic? The person leaves depressed, the person leaves suicidal. So again, it's important to know what defenses are in operation and how they're going to be affected if you put more pressure on people to have feelings. The only exception is that in severe clinical depression, there is no anxiety channel. Davanloo calls it instant repression, that it goes from the feeling impulse right to the defense of depression. And if the depression is serious enough and the ego is depleted enough, the patient will not be able to relate to you. They just don't have the capacity. And so it takes antidepressant medications to lift the depression enough to begin therapy. And so when I would visit patients on the inpatient unit at Rochester General who were significantly depressed, I was going to see them for outpatient therapy, but I would like to show the flag. I would just, when they were seriously depressed, I would just spend a minute or two in the room just so they could recognize my face. As the depression lifted, I would spend more time. Some of the nurses used to get mad at me. Oh yeah, well now that she's feeling better, you're spending more time, but where were you when she was really depressed? And I would try and explain that it wouldn't have helped and it probably would have made things worse. So if you're dealing with people that are seriously depressed, they may be too depleted. The ego just may be too depleted to engage with you or anyone else. And you may have to use antidepressants to lift the depression for a while. So let me get back to full screen, stop share. Okay, we're good. So the last thing I want to emphasize is how emotionally intimate ISTDP therapy is. Again, people who practice it can use it as a, like when our training can become as we're patients, when we're psychotherapy patients, our training can become an extra layer of character defense. It can also become an extra layer of character defense when we're therapists. We get focused on the technique. We get focused on thinking about whatever technique we were trained in. What should we be doing? Is this a highly resistant patient? Is this, and it can become a defense as well, because it requires intimacy on both parts. We both have our triangles of conflict. Just because I'm a therapist doesn't mean I don't have my own anxiety and defenses. And really, at root, it's just two people, two human beings working out a relationship together, an emotionally intimate relationship. That's what it is. I mean, there are parameters. We can both feel anything we want, but nobody acts it out. That we use the patient's feelings to help her heal. And the same thing with mine. Whatever feelings are coming up in me, I'm supposed to deal with them in a way that helps the patient heal. That's my job. And so it's intimate. So when I'm talking to that woman and I say, so where were you sitting when your husband came in at 10 o'clock? Do you see how intimate that is? She's letting me into her life. She's never talked to anyone else about this part of her marriage. It's like it's like you kind of fall in love. Like ISTDP helps you create that kind of intimate relationship. Like when she's telling me that, like I'm falling in love. I'm going, oh my God, look at the courage. Look at what she's telling me. And it's an important part of therapy. Davanloo used to talk about admiration and affection. He used to say things like, when you terminate is when you have the most admiration and affection for your clients. And he meant it. And you could see that in his work, even pressuring and challenging, where I'm pressuring. So if you don't, it's a collaboration. You're not doing it on your own. If you're trying to do therapy on your own, if you're trying to fix someone, not only you're going to resent your client and feel frustrated, but it's not going to work. The client, it has to be a collaboration. And there has to be that sort of affection and admiration that you have for your client. And so when people would, you know, there's this woman who, she was obese. She didn't come for obesity. She came for, you know, depression. But we began to realize that her eating was a defense, was against feelings. And so again, I would portrait, well, what do you mean you ate? What did you eat? Well, I have this stash of cookies in the back of the kitchen cabinet. So you ate in the kitchen? No, I don't. I went into the bathroom. Well, what happened in the bathroom? And she's starting to describe to me locking the door after she puts her sons to bed and climbing into the tub. And she's sitting in the tub with these boxes of cookies on the ledge of the tub, stuffing them into her mouth. And she's describing the crumbs falling on her breasts and the rolls of fat. And she's describing it in detail. That's like, oh my God, that's so intimate. And ISTDP gives you the tools, which you can use as a defense, like any other form of training. You can have tools. And she's having this whole, she's letting me in there, right? I mean, that's incredible. You have to fall in love with someone when they do. It isn't the same kind of love, obviously, I have for my family and friends and so on, but you have to fall in love with someone. That's an important part of the healing process, that mutual admiration and affection. And I didn't have it with everyone. I had it a lot. I had it more as I got older and worked out my own intrapsychic conflicts. It can't be a technique. You can't like make it happen at will. You either feel it or you don't. It can't be the, well, I think I'll have affection for my client technique. You either have it or you don't, but it's an important ingredient in every therapy. And if it's not happening, you want to find out why. Like I came to expect it after a while, the older I got. And why? Why is that? Is the patient doing something that I'm not aware of that's provoking me? Is the patient fine and it's me? And they remind me of my mother or my father, and so I'm defending against it. But it's an important part of your work, no matter what your orientation to therapy, to have that connection with your client. It's part of the healing process. It's part of what they didn't get as a kid. And it's all of our work to find out why that isn't happening with this patient. The last thing is that when I was training with Davanloo, we had to record all of our sessions. And supervision meant that we had to bring a recording of a 4-hour session. The initial sessions were all 4 hours long, and it had to be from the moment the patient walked into the room. And it was agonizing. He would work with you 2 hours on your video while the rest of the group watched, and then it would be someone else's turn, and he would bring videos of his sessions to teach by example. And we would do this like 8 in the morning till 6 at night, Thursday, Friday, Saturday, and most of Sunday. It was grueling. But it was mostly our psychopathology that was on the screen. I mean, the client was who they were. They were depressed, but why was I interrupting? And why was I not seeing something that was right in front of my eyes? And why he did it in a way that was not, you didn't feel demeaned. He was wonderful. He read your unconscious. He was dealing with your, when you're doing supervision, you're dealing with your unconscious, you're dealing with the persons on the screens, on the patients, and the therapist. It's something to talk about in detail. Anyway, so there were times where, like in the beginning of the session, like I would realize, oh my God, this whole session went off in the wrong direction. And I would want to jump ahead, right? I would go, well, no, I think in the second hour I picked this up, and Davanloo would go, no, no, no. He would say, this is a beautiful example. He wouldn't say of what, but he would say, this is a beautiful example. Let's watch this again. he, he wasn't doing it to be sadistic. He was doing it because he knows there's something there that I needed to face. And sometimes he'd make you watch it 2 or 3 times. No, no, one more time. This is do you see, everyone? This is a beautiful example. And so, but part of the training is watching my own videos. Like, I won't learn well by reading. I can't tell you what I wrote in my master's thesis. I think I see Elad there. I think, Elad, you were the first person I admitted this to, that I didn't really read that much about ISTDP because I don't learn that way. I have a learning, but watching those videos over and over and over, hour after hour after hour, it was incredible. It was like free therapy for me. I would blank out at times. Like, I would blank out in the session, and when I was watching the video, I'd blank out at the same, like watching the video, and I had to rerun like sections of the video, like 2 or 3 or 4 times, just to desensitize myself enough to watch it. It was incredible. And so that's an important part of whatever you can do that's self-examining. Whatever sessions you think went terribly, like, don't just put it out of your mind, and don't blame the patient. I mean, the patient had their role for sure, but you want to look for your role over and over. And this is any kind of therapy that you do, it doesn't matter. Over and over and over again. It's free therapy for you, that like working with people that are going to bring up your own triangle of conflict. And you've got one, just like I do and everyone else. It's important that you look at that. And that's some of what I'm also going to focus on in the trainings coming up, is that sort of experiential, phenomenological experience from the therapist's point of view. Very important. So, okay, well, I ran 5 minutes over. I have no idea if this was helpful. So here's the deal. If people want to hang around and unmute and ask questions and make comments, I'd be willing to hang around. That would be fine with me. It's what I envisioned anyway, and maybe we can do a little bit of this as an experiment. If people want to check off and you know, do something else, that's fine too. So if anyone needs a break, unmute and say I'm going to take a break, and we can come back in 5 minutes. That would be fine as well. Okay, well, does anyone have anything to say or questions to ask? Sure, why don't we do that? Why don't we take 5 minutes, and who's ever back here in 5 minutes, we can chat. And whoever isn't, thank you very much for coming. I hope this was helpful. I have no idea because I'm just looking at this computer screen if anything I said was relevant, but I hope so. And I'll see everyone who wants to hang around back in 5 minutes, okay? So anyone, thank you for the compliments, everyone. I really appreciate it. I had no idea this was going to be helpful. I'm glad it was. So anyone have any other comments or questions or concerns or anything else? Okay. The main thing is the clarity. Like, I had a client whose family was connected with the mafia, and she had some realistically pretty scary things. And they were really scary. It wasn't like, oh shoot, I left out a really important thing. Well, everyone who's stuck around will get it. The anxiety, thank you so much for the question. Yeah, Bill, you'll know this, who taught it. The anxiety in the upper right part of the triangle, that signal anxiety, is unconscious. The anxiety, you're feeling the anxiety, but why you're anxious is unconscious. You're not going, oh, I'm feeling anxious because I repressed wanting to strangle my father, and that's hard to face, and so I'm getting anxious. The reason you're anxious is unconscious. And so oh God, I can't believe I left that out. I want to call everyone back. Call yourself a therapist. I guess we've never done a perfect session, either of us. That includes this one. But it's unconscious anxiety because you don't know why you're anxious. That's the whole part of therapy, is to make that conscious. And then you could feel it, and then you don't have to. And so that's the other thing, Estelin, is what they're afraid of is conscious. Like, if you're If there's a big exam coming up, you'll be anxious, right? But if it's coming from the lower part of the triangle, you'll know why you're anxious and you'll be focused. That anxiety will be adaptive. It will motivate you to study. It will motivate you to concentrate. If the other kind of anxiety is mixed in, you'll be beating up on your. Exactly. That's a good way. That's a precise way to put it. Exactly. And so, is there really something to be afraid of? And what happens with anxiety, that's really a real thing that you should be afraid of, is you get more focused and you're able to react more quickly. Like it bypasses the cortical layer and it goes right to the subcortical. Like you have to be able to react without thinking. And it's a survival thing that has allowed our species to survive, to be able to bypass the cortex and just react instinctively. That's adaptive.
Mm-hmm.
So to determine that, again, you want to go to the person's state of mind and what the circumstances were and so on, to determine, is it coming from the lower? And then you want to say, well, yeah, how else would you feel? That was scary. It's even scary to face what's behind your wall. Like that's not a defense. Like Davanloo has said sometimes, I know it can be terrifying to face the truth of what you're feeling. That's not a defense. It really is scary. But together, you and your role, that term together is really important. You and your role, me and my role, together will face it. And we can get to the bottom of it and you can be a free woman. It's really important to, so if someone's getting anxious, even in the session, Estelin, you want to say, is it just because it's scary to? Well, sometimes that's the way to go. Sometimes it creates a misalliance and the patient doesn't feel seen. Well, that's the other thing, is you're not Ellen Abbas and you're not practicing in a medical setting where people have been prepped and people understand the connection between the mind, the feelings and their symptoms, and people know about ISTDP. But also, I would bring you into the room. And if you're uncomfortable with that, do it your way. It's fine. Like Davanloo did it his way. I developed my own approach, which I'm comfortable with. I've been telling people about Bernie Schwartz. Bernie Schwartz was I should say this I'm going to say this at the seminar too, because it's a good example, but Bernie Schwartz was the chief psychologist in 1980 when I applied for my internship, my APA internship at Rochester General, and he interviewed me. I've never saw him before. I walked in for the interview. He, was like, how are you? We sat down. He started explaining to me about the internship. He said, are you interested? And I said, yeah, it sounds like exactly what I'm looking for. He says, good. He said, let me ask you a question. This is like 3 minutes. This is the whole interview. He says, you seem like a nice guy. He said, I bet you'd like to be supportive and kind to your patients and just be supportive no matter what, so they feel accepted and cared for. And I said, well, yeah, I guess I do. He goes, I hate people like you. You never help people. You just support maladaptive things. And I'm looking, it's like, he said, do you have any other questions for me? And I said, no. He said, good, well, we'll meet, the committee's meeting and I'll get back to you soon. And I walked out of there and my wife at the time said, how did it go? And I said, I think he likes me. But if I just look at his words, he hates me. He could do that. And he called the next day and he said, the committee is met and you're a lovely young man and we'd love to have you here. He said, here's your start on June 1st. Bernie could do that. Bernie could say to a patient, I was walking into his office and he's on the phone and he goes, psychotherapy, he's from the Bronx. Bernie was like 60 years old. He was raised in the Bronx. He served in World War II. He went to school on his veterans benefits, and he had the record for the shortest doctoral dissertation in the psych department at Harvard. He was a brilliant guy, but he looked like a Bronx street guy. And he goes, psychotherapy is as useless to you as tits on a bull. You're paranoid as a fucking bedbug. Get in here and take your medication. And he hung up. The patient felt loved. Only Bernie could do that. I couldn't do that. And I know as I describe it, you're wondering how could that be that people felt loved? He did it. That was Bernie. Like no one else can do that. No one else can do what Abbas does. And you're such a wonderful person and you're so experienced as a clinician. Just bring your whole self into the room and let ISTDP enhance what's there rather than trying to do what Abbas does, which I'm sure he wouldn't want you to become a clone. I know him some. He wouldn't want you to become a clone of him.
Yeah, agreed.
Mm-hmm. And so it's really important. Like Bernie was the first guy to point out that we have our own triangle of conflict. This is before Davanloo. Bernie says, this is to the intern, he's teaching these seminars for the interns. He said, if a client is different than you, you're going to have prejudices, different gender, different race, different ethnicity. And if they're not doing what you want you to do, you're going to have feelings. And your job is to be aware of those feelings, because if not, they'll seep into this is pre-Davanloo, right? This is pretty cool. This was my training. And so we were getting a little defensive. Like, I don't know about the prejudice. And he goes, really? He said, that book, I'm okay, you're okay. And we said, yes. He said, well, it should be, I'm okay and you're barely tolerable, even under optimal conditions. like only Bernie could say that, like no one else, right? I can't imitate his brother. And what feels right to you. I think that's totally serving your patients in the best way possible. So. Yeah, it is. There is some cognitive impairment. It may not be extreme, but let me give you an example. So let's compare the two cases that I talked about. The first one was the guy at TOPS, okay? The second one is this woman who was strangling her father. Okay. Her father rejected her whole life. She left home, surprise, surprise, at 17 and got pregnant by some ne'er-do-well, had nowhere to go. So she came home and the father fell all over her. Couldn't do enough for her. Bringing her stuff. Can I get you something? Can I cook? She was like, what happened? This is like the father I've always wanted. As soon as the baby was born, the father said, you have to leave as soon as you're recovered from the delivery. Your mother and I are going to raise the baby. This is our baby. You're too immature. You have to leave. You can imagine how enraged he was, right? Because she not only did she have all that from her childhood, but she opened her heart and then got slammed again. And so she's leaving with the baby to visit a friend, and the father's trying to pull the baby out of her arms. And then the next thing she remembers, she's on like strangling the father. That's extreme cognitive behavioral disruption. Okay. The guy from TOPS remembered everything. He remembered what the guy said to him that was so insulting. He remembered pushing the cart. He remembered the guy pushing it back. Like he remembered every detail. So his disruption was not nearly as severe as the woman. I could push him a little more and feel confident, but not with the woman. It took 20 sessions with that woman before I felt confident pressuring her to the degree that I pressured this guy in the first session, the accountant. Does that make sense? I was running a group at Rochester General, and we were talking about how we dealt with our anger, the first group. And one guy said, I walk away. And I said, really, why do you walk away? And he said, because the last time I felt my anger, I murdered my wife. And he was in prison for 13 years, and he was out on parole, and coming to my group was a part of his parole. Okay, we're not pushing that guy, right? Does that make sense? And so when you're making the differential diagnosis, you want to determine how much does the person remember, what degree of, there's some degree in a temper tantrum of cognitive disruption, but again, there are degrees. Another guy I saw, he remembers arguing with someone, and the next thing he remembers, the guy's on the floor bleeding with his eye damaged. And he's standing there with a broken glass beer pitcher in his hand, and he doesn't remember what happened. Okay? So it's those kind of determinations. And Davanloo gave us the tools to do that, right? Okay. Did that answer your question? Okay. Okay, good. Thank you for the question. Oh, that's a great question. Okay. So here's the thing. Sometimes you have to support the patient's defenses. I know this goes against ISTDP orthodoxy and, you know, Alan's wonderful teaching videos and his wonderful work. And I'm really grateful to Alan and Patricia and all, you know, it's wonderful. But if you've had a lot of bad experiences being open with people, like you got clobbered and hit, or you're going to be reluctant to do it again. And it's reasonable. And what you want to say is you want to say something, I don't know if this is precise, so let me know if I'm off the mark, but you want to say something like, so there's a part of you that's reluctant to tear down your walls and allow me close to you. There's a part of you that wants to, there's a part of you that's reluctant. Davanloo used to say, so there are these two parts of you battling inside. The part of you that's reluctant deserves a voice. Can you tell me more about that part?
Right.
They might say, well, every time I let my parents close to me, they hit me or they shame me or they whatever. You have to be able to say, well, no wonder you're reluctant to do that. That makes sense. Why would you want to go through that again? You probably promised yourself you were never going to let anyone close to you. That makes sense. The patient then feels seen. And the resistance is conscious. It's very important that the resistance be conscious. And if it's not, you want to say, well, speak to me from the side of you, even if it's only 10% of you that wants to leave that wall up. That side of you deserves a voice. We need to bring him or her into the session. Then you can say, so that served you well as a child. That was an adaptive thing to have done, but it doesn't seem to be working all that well for you as an adult.
Right.
And then you can point out the downside. It's crippled your life. You've had 3 failed marriages. This is another relationship, if you leave the wall up, where you're not going to get what you came here for. Do you want this to be another relationship that you don't get out of it what you want? There's that side as well. And so really, it can't be a manipulation like a paradoxical intervention. It really has to be, you weigh the pluses and minuses, and you have to accept that they may decide to leave the wall up. It seldom happens, but you have to ask the question in that spirit of, this is a tough choice for you. But by pointing out the downside, what you're doing is you're making it an informed decision that there is the safety and familiarity of the wall, but you're letting them know very graphically how painful it is also to maintain the wall. So it's an informed decision. And sometimes you have to be patient. Again, it's almost never happened that sometimes it's 2 or 3 sessions where the patient has to deliberate. It's okay. That's what has to happen. Maybe Abbas, in his personality, in his clinical setting, could get all that done in the first 5 minutes. I found that I can't. I have to really bring the patient along and come along myself. And I found that to be the fastest way for me sometimes. Does that answer your question? And that's me. And you do it your way. Like, no, I don't want anyone to do it my way either. This just worked for me. Yeah, that's a great question. You know, the conscious will is a prerequisite for anything to happen. And it has to be as important to the patient and probably more important than it is to you that they get to the bottom of their problems. And how you determine that is obviously different with different patients. You'll see the patient that I'm showing in the second, the fragile woman with bulimia and migraines and so on. She finally says, okay, I want to take down the wall. So sometimes it's just clear. And sometimes it's more subtle, like in the first video I'm going to show. But one of the ways to tell is, for example, when you're confronting someone about their this defense, and you're pointing out how it's crippling their therapy and crippling their life, you want to see them start to agree with you. And one of the ways you can tell that that defense has sunk in is if they present you with another defense. Then it's the Conscious Therapeutic Alliance saying, okay, we got past this one, but now what are you going to do about my defiance? It's a beautiful thing. It opens your heart that they're like being that, they're telling you where to go. And when you, like Davanloo, like see the thing about ISTDP, like I did a demonstration many years ago, a demonstration therapy session in front of a panel of Gestalt therapists on the West Coast. And they said, what orientation? And I said, psychoanalytic. And they all, went like that, like, well, they were all Gestalt people, but they really liked the session. And one guy said, well, that's an advanced application of Gestalt techniques. Like he liked it, so he wanted to own it. But anyway, they said in Gestalt therapy, we don't confront defenses because you get more defenses. And I said in ISTDP, the same thing happens. Obviously, we're dealing with people, but that's a good thing because then that defense comes out and it can be identified as a defense. The patient can be turned against that defense. How long have you spent helpless and crippled, and do you want to do that? And then the next one comes out. And Davanloo, who's the old military guy, used to say, you don't want a battalion of tanks hidden behind the hill that's going to come out and surprise you. Like you want everything out in the open so you and the patient can join to turn him or her against that defense. Does that make sense? But you're always going to the will, all throughout, even in heavy pressure and challenge. What are you going to do about this crippled man? You're not a crippled man. What are you going to do about this crippled man? Do you want to stay crippled? Maybe you want to stay crippled. Maybe you'd like to leave. And, you're always playing to the conscious. You're never saying, well, we talked about it in the beginning of the session, so I don't understand why it's a problem now. It constantly has to be repeated. It's part of the fabric of what you're doing, is always reinforcing that conscious therapeutic alliance. Always, always, always. And so it's a prerequisite for moving to the next phase of therapy. But you're never assuming you got it. Did that answer your question okay? And
Yeah.
you see, even in heavy pressure and challenge, and the patient that I'll be showing at the 20 on the first one, can tell he's with me. We're working together.
Mm-hmm.
And there'll be signs that I'll point out in the video that you can see he's working together. We're on the same page.
Yeah.
You can't do pressure and challenge. That's fixing people. You can't be fishing for anger. Davanloo called that's Davanloo's term, fishing for the anger. I love it. It's not going to work. You can't be trying to fix someone. You can't be trying to drag someone through their defenses. You can't be trying to convince someone that they're really angry instead of depressed. Davanloo called that bargaining with the superego. It doesn't work, and it's aggravating. And that love that you want to feel for your client turns into resentment because it's like they're not cooperating. I want them to do this. And so it is dogged, but you can't be the only one working.
Yeah.
Otherwise, you're going to just be aggravated. If the patient is working with you, if you're collaborating together, it's hard work, but it's not aggravating. It feels good at the end of the session. Like you worked hard. That feels good. That's different than feeling like you were over functioning and doing more than your part, and then feeling kind of drained and aggravated. It's like a whole different feeling.
Yeah.
Okay.
I got a question.
Sure.
Do you ever see clients where traditional pressure and challenge doesn't make sense just based on who they are and what they've been through?
Yes.
And if so, could you talk a little bit about that, how you work with those people?
Yes. Because Davanloo fired me and excommunicated me in 1991, and there was no abbess, or like they all came after me. Like, I'll talk more about that in the big supervision if you're interested. I had to bushwhack. I had nobody to train with, and I had to figure out my own devices for dealing with when pressure and challenge isn't working, and it doesn't work all the time. It especially doesn't work if someone is trained as an ISTDP therapist or has had extensive ISTDP therapy before they saw you. It doesn't work.
Mm-hmm.
It's just too contaminated. My therapy didn't help me. We'd had this core, peer supervision group for 4 or 5 years, and we all wanted therapy from Davanloo. And he didn't have the time, so he referred me to this guy, Chris Zoyce, in New York. I flew in once a month for a 4-hour session in the morning and flew back in the evening. It didn't help me. And in hindsight, that's why. He would start pressuring, and I go, okay, well, now he's pressuring, and now he wants me to kill my mother. And now it's like I would sort of do it because I knew I was supposed to, but it didn't have much therapeutic effect.
Mm-hmm.
And so how you work with people depends upon the people. But the main principle is your job is to see what's going on inside of them. That's number one, whether it's where they are in the triangle of conflict or what's happening with the pathways of anxiety or anything else. Your job is to create that intimacy and to stay connected with who they are. The second job is to get their will that they really want to change. Mm-hmm. And to sit with not knowing. It's not like I developed techniques. Here's what you do. That would just be anti to the whole thing. Here's what you do when pressure and challenge isn't working, right? Mm-hmm. Mm-hmm. And you sit with not knowing. And sometimes you don't know. And even Davanloo did that. Like Davanloo's technique, he's honest, comes out of his intuition. He was just trying to explain to the rest of us what he did. Mm-hmm. And he would do things like he'd show us videos of his sessions, and we'd go, "Oh my God, he didn't teach us that." Like he didn't, it's like we'd be so mad. He never taught us that. And I've talked to people who were in therapy with Davanloo, and they would say things, and I go, "Wow, that was really great. Like he never taught us that, Mm-hmm. So to sit with not knowing, but bring your whole self in. Don't assume because ISTDP doesn't look like it's going to work that you got nothing. You've got your whole life experiences. And Davanloo used to say things like, well, this is the first obstacle that we face in our work here together. And sometimes I've had to say, whoa, the very thing that I need to help you, which is for you to be open and honest, is the last thing in the world you want to do because it's been such a bad experience. I go, whoa. I said, that's really a problem. Now I'll say out loud, I'm not sure how we're going to deal with that. Mm-hmm. I'm not sure how you're going to change. The unconscious here is you're going to change, right? Because there's no negatives in the unconscious. It's important that you phrase it that way. Mm-hmm. You say, given your state right now, I bet you can't imagine how you're going to get over this marriage and get on with your life in a way that's satisfying to you. In the unconscious, there's no negative. What the unconscious hears is, get over your life in a way that's satisfying to you. Like who's that guy? I can't think of his name. Like when he was a kid, he went to this mill. They had a mill, a water wheel, and his mother said, don't get near the edge of the pond because you might slip and fall in. What his unconscious heard is go near the edge of the pond and slip and fall in, which is what he did. Mm-hmm. Mm-hmm. The mother had said, be careful and stay away and take care of yourself. It would have been a different thing. So sometimes you just got to sit with not knowing. And in fact, the video that I'm showing in the second training of this fragile woman, I start asking her about her family's restaurant because I don't know where to go. Mm-hmm. She's describing that it's this, and we live in the same house, and the kitchen is here. And I go, really? Was the kitchen to the right or the left? You just have to trust that if you surrender to not knowing, that something's going to happen. This isn't a technique that I can give you. I can tell you some of the things I've done, but it may be like Salvador Minuchin and the Philadelphia child guy. We wanted him to come to the hospital and he couldn't come, but he sent his second in charge, who was a guy named Jorge Calapinto. And it was great because they showed videos like no one else other than Davanloo. And so I went out to lunch with him during the break and I said, the videos are great. How do you decide which ones to put in your roadshow? He says, well, we have to be careful. Some we have to take out. And I said, really? Like what one did you have to take out? He said, there was this session where the therapist took off her shoe and hit the father on the arm. And it was one of those in the moment thing that jarred the father. And there was this outpouring of tears and crying, and it unblocked the whole family system. For those of you that are Bill who does family therapy, just the whole family system responded to that. And he said, but we had to take it out. And I said, why? He said, because we get letters, something to the effect of, I love your presentation, and especially when the therapist hit the patient with the shoe. I've been hitting my patients with my shoe, but it isn't working. You know, so that would be the only time that would happen. So that's what I would encourage you to do. And maybe at the seminar, I can talk about some of the things I've actually done, but I wouldn't want you to do those with anybody else other than that patient. Maybe, you know, maybe that's in general. So that's my answer. Did that answer your question?
Thank you. Yes.
Okay, good. Okay, anybody else? Any questions or comments? And if not, we can adjourn.
I thought I would, I know I just asked something, but just piggyback off of the anxiety issue.
Yes.
You talked about the channels of anxiety. What about where a patient is very disengaged and you don't see striated signaling, they're not nauseous, they're not having cognitive perceptual disruption, but they look really detached. You want to talk about that a little bit?
Yeah, there's a fourth possibility, which you'll see in this video on the 23rd. This guy is intellectualizing, he's ruminating, he's philosophizing, which is what he had to do with his father. His father wouldn't talk to his children until they were old enough to discuss Plato. He even said, I'm not going to get philosophical. I didn't know what it meant. And there's no anxiety, there's no striated, because there's no feelings being mobilized. That's why. You have to be mobilizing feelings to mobilize that anxiety. And in fact, it's optimal to have some mobilization of anxiety where something is happening at the feeling level. So that could be one thing. The other thing is it's kind of this macho ISTDP thing that you have to be able to read the patient and know where the channel of anxiety is. I can't sometimes. And Davanloo even said sometimes all three channels can be simultaneous. Sometimes it isn't one or the other. You can have some striated at the same time, you can have some cognitive disruption. At the same time, you can have some smooth muscle activity. I don't move forward until I know where the anxiety is. And sometimes you just got to ask. I know that's an ISTDP kind of wimpy thing to have to do. You should be able to know everything, but I don't. And I ask. And if they're not being clear with me, I keep asking. Because I don't want to move ahead unless I know where those channels are. I'm not jumping ahead. You got to be in the moment. You can't be sitting there thinking, oh, I should be pressuring. You've got to be, well, what's happening right now? Like that, I remember one time Davanloo stopped me and he said, okay, you said this and this and this and this to the patient. And I said, yes. He said, how did the patient react to the first thing you said? And I had no idea because I was on to the next things. He emphasized this as an intervention and response model. You make an intervention, you wait for the patient's response, and that response determines your next intervention, not some roadmap that you have from your core training. Does that make sense? So don't know. That's okay. You're experiencing tension anywhere? No. Are you sure? No. And you just keep asking till it's clear to you. So what else is going on? Describe your state of mind. And by the way, I found it not helpful most of the time to ask people right away how they feel. How did you feel when your husband came in? How toward him? That's an ISTDP box. And you tend to get less information than if you say, how did you react? Describe what was going on the inside. They know when you say, how did you feel toward your husband? They know that the right answer is anger, and it already limits what they're going to say. This way you get their response and you can sort out what was a defense, what was and so ask. And if you're not clear, ask again. Okay? But it could be that you're just not mobilizing feelings. So there's no anxiety, and that happens in this session, which is one of the things I'm going to point out. Okay? Good. Great questions. These are really great questions. Thank you all. Any more? I'll wait a minute or so in case someone's inspired, and then we'll say goodbye. And we'll go from there. Okay. Well, thank you all very, very much. I was expecting 10 people, and I'm so wonderful that you all showed up. I hope it was helpful. I have a weird, quirky